And really, patients that we're just concentrating on the scale, they're losing 20, 30 pounds. They don't feel healthy. They feel frail. They feel weak. Versus a patient that's lost 50 pounds of body fat, but they maintain muscle or they gain muscle, they feel strong. They feel the feeling overcomes the looking or how they look, which is, I think if everybody understood that, we would see so different as medications that is about how you feel health-wise and not how you look. I think many people are poo-pooing these medications because they're thinking it an external, superficial
it's a cheat.
result,
it's like you're
right?
cheating,
just to look a certain way.
Dr. Rocio Salas-Whalen, welcome to The Better Show. I'm thrilled to have you here today.
Thank you for inviting me. I'm very happy to be here.
Awesome. All right. So as I was talking to you in the pre-chat, I definitely want to be talking about obesity, the obesity epidemic, and then some of the newer pharmacology that I shouldn't say new, but we'll say in popularity. In the common layperson, everybody's heard of Ozempic. So I really want to talk about GLP-1s and what they do in the body. And then I also want to talk about hormones as well. Mm-hmm. One of the things that I absolutely love is that you talk very openly around HRT for women in perimenopause and menopause and some of the applications of it. So let's start with obesity and let's start with GLP-1s. And actually, even before we get to GLP-1s, obviously this is a peptide. This is something that every human, hopefully every human, endogenously produces on our own. Let's talk a little bit about how that happens in the body without something like an Ozempic or a Mounjaro, and then we can move into the pharmacology of a GLP-1 agonist.
Definitely. So glucagon-like peptide 1 is actually a gut hormone that we make in the L cells of the small intestine. And to be produced, food needs to pass by. So every time we eat and the food starts to get digested and passes through this specific area of the small gut, we release this hormone. This hormone helps pancreas produce more insulin, regulate your glucose, and we're finding more and more receptors around the body for this hormone. The problem with endogenous GLP-1 is that it's very quickly degraded by an enzyme. So the half-life of endogenous GLP-1 is about 2 to 4 minutes only. The analogs that we have, the synthetic form, are more of a long-acting version of this hormone that we produce in our gut.
And so the half-life for an exogenous like an Ozempic, so you said 2 to 4 minutes,
endogenous,
sort of maximally.
Endogenous GLP-1.
Endogenous. So what is the half-life, or do we know what the difference is between an exogenous GLP-1 versus one that we're intrinsically producing?
So we have the subcutaneous injection, and that has about a 7-day half-life. So they're longer acting. And then we have an oral version that is a daily 24-hour half-life, right? Before the earliest versions that we had, which was exenatide, also called Bayera, it had a 12-hour half-life. So we had to use it twice a day.
Okay. So now we've seen through maybe the evolution of these GLP-1 agonists as well, is that the half-life is longer. And of course, what happens when we have a GLP-1, whether it's endogenous or exogenous, it's reducing or it's tampering down on our appetite, correct?
Yeah. So what they do is they increase our satiety hormones when we start eating. So we get fuller with smaller portions of food. And then in between meals, it suppresses your hunger hormones. So you're not feeling hungry in between meals. You get hungry, but then you get physically satisfied with a half or a third of what you normally would need to get full. And then in between meals, it suppresses your hunger hormones, right? But we have receptors, if we're talking about how they act in regards to weight loss, we have receptors in the hedonistic eating and drinking area in our brain called the amygdala. And what it does there, they block the anticipation of our reward from food. Right? So people that eat for anxiety, boredom, late night eating, binge eating, that they're anticipating a reward, it just blocks it. So you eat more for fuel, right? You eat when you're hungry, you enjoy your food when you're eating, but then you only require smaller portions through the day.
That's really interesting because obviously there's two main reasons why we eat. One, you just identified, right, is the anticipation of the reward. You know that you're going to the wedding, you're going to have the wedding cake or your favorite, my husband's favorite sort of comfort food. He's Italian, so he loves tiramisu. So that in consuming that comfort food, let's say, there's less of that dopamine. I'm assuming there's less of that sort of dopaminergic release that would happen after the food. So you don't get the same, let's say, bump after consuming, and more the sort of hedonic pleasure in the brain. The other reason is survival, right? So we eat, we have to eat.
Exactly.
Yeah. Okay. So that's really interesting. And I have just a side question on this before we get into it. But would you, or maybe you've seen this clinically, maybe someone doesn't have an issue with eating. I know 100% of us always have to eat. So, the likelihood of having some dysregulated relationship with food, of course, is more rampant. But is there, where you may be treating a patient for obesity, often vices tend to, there's multiple addictions, let's say, that can happen at the same time. So maybe there's a food addiction that you're dealing with, the tiramisu or the cheesecake or the wedding cake, whatever. And then we also see other types of behaviors like spontaneous shopping, like going and just spending, making an Amazon haul, like buying everything on Amazon or in person, or smoking or gambling, or any of these sort of, we'll say, addictive type behaviors. Have you seen any crossover with taking some of these drugs and a reduction in the drive for those type of addictive behaviors?
So they specifically work in the eating and drinking part of our brain. So what I have seen is like alcohol, right? So for many, alcohol has a social reward, some sort of relaxation or anticipation that you're gonna get when you have a glass of wine or a drink. It removes that too for some patients that smoke. I've seen that happen too. In regards to other behaviors like gambling or shopping, I clinically haven't seen that to translate or to transport into that area. Right. But I have seen some articles here and there, but there's no studies that we can say, yes, this is going to help also for this part.
Yeah, it's interesting to see how when we see a more widespread application or adopting of some of these peptides, which seems to be happening, whether or not there'll be some bleeding over, let's say, into some of these other behaviors, because I think that dopaminergic, that you have this large release of dopamine, and in patients with obesity, of course, this is well established that their reward centers typically are more active. Yeah. We typically see higher activity in patients with obesity to food rewards, right? But it'll be interesting to see if that will cross over to other behaviors as well.
I mean, I do think there's an explanation for that. If we see changes in that type of behavior, is, let's say, the patient with obesity that starts one of this medication, that starts implementing a different lifestyle, right? Because for many patients, maybe that's a reward for them because they can mentally or self-consciously, they don't have that confidence and they may spill into other parts of their life to overdo it. So it may be just a change in complete lifestyle that may also they adopt healthier lifestyle choices.
Right. Okay. So let's talk a little bit about obesity. Many have called it an epidemic. I would agree with that classification. I've read stats that 90% or more of North Americans have some type of metabolic dysfunction, which will include poor glucose control. And then in terms of just obesity or excess adiposity, I think that it's predicted that 50%, something, if we're not already there yet, of the United States and Canada will be obese. And I want to say it's 2030. I might have that number wrong.
The WHO estimates that in 2030, 50% of the world population will be classified with obesity.
What do you think is driving that epidemic?
So there's different causes of obesity, right? It's not what we knew or thought before, that it was purely lifestyle induced. We know that it's multifactorial. And I think if we go by the causes, that will answer the question. Definitely one part is lifestyle, right? So depending how we're eating, how are we active or not active, that definitely can contribute, but it will not cause it 100%, right? We have genetic factors, right? So usually somebody with obesity, overweight, if we go to their family tree, there's going to be some obesity in either side, or in some patients in both sides of the family, they will have obesity. That accounts about 40 to 50% of why somebody would have obesity is family history. then
Is it the family history or is it the behaviors that were modeled in that family?
there's so much data now that
It's like the nature nurture question, right? It's like it's the
there's
nature versus
there's
nurture.
so much data now that the mother and the father's weight preconception will impact the offspring's weight, right? So if somebody is overweight or have obesity and they're going to conceive, then that child already has about 40-50% probability to have obesity in their life. Now, there's some studies that is showing that we're not only that getting through our genes, but highly palatable taste is also being genetically transmitted too. So even the taste for possibly processed food, ultra processed food, is getting inherited now. So it goes beyond what a person can do in their life. If their parents, grandparents are exposed and have obesity, then that already gives you 50% chance that you're going to have obesity, right?
And is that, and just so my understanding here, is it that genetic or is that epigenetic?
Epigenetic.
It's epigenetic. Because when I think about my family, so on my father's side, Portuguese immigrants to Canada, all morbidly obese, all had type 2 diabetes, refused their doctors, like they just needed their lard with everything. And then on my mother's side, they're Lebanese, from the Middle East, and, sort of half and half, right? So some of them were overweight, some of them weren't. And so if you think about that if I look at myself as an N of one,
Mm-hmm.
I should be obese. And when I was younger and I was eating a lot, when I was modeling their behaviors, like overeating,
Mm-hmm.
Sunday dinners,
Mm-hmm.
like all the food and all the, then the dessert and of course that would predict my obesity or my, how much adiposity I was carrying. I had a mother who was very like kind of a health nut, if you will, like very much into food and very much into exercise. So I was able to benefit from sort of her philosophy and the way that she was moving. So I always wonder when we're talking about obesity, certainly I agree with you that there's a genetic component, and we just sort of touched on that one where, the reward centers in the brain for individuals who are, and I have this too, like when I eat something that I really love, like it's really hard for me to stop.
Mm-hmm.
So that sort of reward center feedback loop certainly can make it much more difficult for those individuals to manage the caloric intake that they're taking. Mm-hmm. And I wonder, and this is where I would love for you to weigh in, the epigenetic changes, like above the gene is something that we can possibly affect, right? We can affect those epigenetic changes. Exactly. We have some agency over it.
So the perfect example is your mother. Yeah, no, the perfect example is your mom, right? That she has genetically that predisposition, but she changed her environment. She changed the way that she eats, that exercises, so she was able to modify. Very similar type 2 diabetes, right? Somebody can be predisposed genetically, but they modify and manipulate their environment to prevent from developing the disease, right? But if they wouldn't do that, if they wouldn't do those changes, if your mother wasn't a health nut, as you called, then probably and most likely she would have developed obesity herself too, right? And that's one part that we call the environmental causes of obesity. And that is a perfect example, is what we're exposed, right? The food industry, the plastics, the endocrine disrupting chemicals, all of that they promote obesity. So if you are able to really minimize those effects of the environment, also where we live, does it promote walking? Does it promote sedentarism, right? So those things can be more modifiable than you modifying your epigenetics, right? Your gene inheritance. There's things that can be done to modify that. Then we have hormonal causes that can also promote obesity. We have PCOS, we have perimenopause, menopause, right? All those changes in our hormones can promote body composition changes, can promote obesity. And then we add aging to it, right? So aging can also promote weight gain and obesity because we're decreasing our metabolism because we tend to lose muscle mass as we age. So if you think about it, it's really more complex than what we used to think of, just eat less and exercise more. And that's what we were always recommending our patients for decades. And they were not losing weight, right? And patients were actually doing what I'm discovering in my clinic, or that I have discovered in my clinic, is that patients were actually listening to us. Patients were actually doing the legwork that we were asking, but we were not accounting for genetics, environmental, hormonal changes, aging that was making it very hard for the patient. If they just try to modify one variable, it becomes not sustainable because of all the other factors promoting and pushing the patient to gain weight or make it difficult for them to lose weight.
Yeah. Yeah. And I think to your point, I agree with you in this, with this idea that obesity is much more complex than eat less, move more. And I feel like even that advice is really very vague. Like, eat less of what? Move more how? So I think that when you think of eat less, move more, most patients are going to over aggressively calorically restrict, which of course causes this rebound. We all know, we've all tried it. We're like, I'm going to reduce my calories by 500 a day, so I can lose 1 pound a week. And like, that's too much of a caloric deficit for many individuals. And then when you think of move more, it's usually, well, I'm going to get on the treadmill and run.
Yeah.
And getting on the treadmill is great for your cardiorespiratory fitness, great for your, pulmonary function. And what you're going to do on the treadmill, especially if you are not incorporating weights and resistance training, is your body is just going to get smaller overall, right?
Yeah.
Which includes a loss of muscle mass, right? So your body's going to say, okay, she's running all the time now, so I'm going to be more efficient at running. And in order to do that, this muscle over here in my arms, in my back, and even in my legs, I don't need this. So let me just take all the amino acids out of that and then just lose it.
Yeah.
So I think that eat less, move more mantra is very non-specific. And I think in many cases, most individuals who hear that from their clinician are just like, all right, I'm going to have a grapefruit for breakfast. And I've had women tell me I have grapefruit for breakfast and then an egg, one egg for lunch, and then some like cottage cheese or something for dinner. And it's like, that is not, and you are going to fall off of that program so hard, because it is, anybody can do that for maybe a week, maybe even a month, but you cannot sustain that long term. Like, that is not something that feels good and that can be sustained over the long term.
Yeah, and one thing that I'm discovering in my patients, because I do body compositions on every single patient from day one till chronically, I do body compositions on every visit. And what I'm looking is patients that when we do like those non-sustainable, severe restrictive diets or caloric intake, if we're not looking at a body composition, what the patient is mostly losing is muscle mass, right? And when you lose muscle mass, you slow down even further your metabolism. So you would have to even eat less calories to sustain the weight loss. And that's why that doesn't work, because you're losing muscle, and muscle is our burning calorie machine, right? So it's actually counterproductive when we were recommending that, right? Or when we're just quantifying weight loss by a number in pounds, with not really knowing what the patient is losing, and they may be slowing even more their metabolism, and it's going to become even harder for them to lose weight.
And I think that was the initial criticism of GLP-1s when they were really surging in popularity. It's like, oh, we see people losing so much muscle mass, like up to, I was hearing reports like 40%, 50%, like of the weight that they were losing was their muscle mass. And certainly, very likely in those patients, they weren't prioritizing resistance training. And because of the severe caloric deficit that they were probably under, much like the grapefruit and the one egg and the cottage cheese diet or whatever, losing, precious currency, our muscle mass.
Well, the problem is not the drug. The problem was that they were not getting the right supervision, right? Because when you start a patient on this type of medications, you have to have a discussion about nutrition. You have to have a discussion about strength training. So patients are not properly supervised through the journey, and those were the results that we were seeing, just losing muscle mass.
Okay, so when we're thinking about obesity then, first maybe let's talk about who qualifies, how do we quantify or qualify someone to be obese? And if they do qualify for that diagnosis, should everyone who is obese be offered something like an Ozempic or a GLP-1 agonist? And then the second question to that is, even if you don't qualify as obese. Let's say your BMI is over a certain amount or whatever. But maybe you're going through perimenopause. I've spoken to Dr. Mary Claire Haver about this change in phenotype of fat, where now we're starting to see this accelerated accrual or accumulation of visceral fat. Is Ozempic or a GLP-1 agonist an appropriate intervention for everyone who qualifies for obesity? Or if you're just seeing some of the like age and perimenopause and hormonal status changing, should this also be part of the first line, let's say, of treating what's happening there?
So I think to really what we need to do now is to try to move away when we're talking who will benefit or not from this medication or who's at risk for disease because of their weight. We have to really start to step away from the BMI. And even the American Medical Association came with a statement early this year that really the BMI should not be a tool to really say who or who doesn't meet criteria to benefit from weight loss medication, right? So we obesity specialists, we're using other types of measurements to determine if a patient will benefit or not from these medications. We use percentage body fat, we use visceral fat, and also we see the muscle mass, right? So really those three components are very important. And it's not so much, I hear a lot of the BMI. Maybe somebody has a high BMI because they have high muscle mass.
Well, they would be obese, considered obese if they have a lot of muscle, right? Yeah.
That's not the common. We don't see that often. It's not that we are over-diagnosing overweight or obesity. We're actually under-diagnosing overweight and obesity if we use the BMI. Because many patients, I see a normal BMI, but it's normal. Why? Because they have very small muscle mass. So the BMI is just an average between your weight and your height, but it's not telling us your body composition, what's what inside your body, right? So many times a patient may have a high body fat and a very low muscle mass, and that would average a normal BMI. But that patient is still at risk for metabolic disease, right? And is still risk for inflammatory diseases that promote like as cancer or any metabolic disease and type 2 diabetes, insulin resistant. So we are actually underdiagnosing who will benefit from these medications. Now, do everybody has to go on the medication? That's a very broad statement, right? What is important is a very individualized history and individualized case of needing not the medication, where we take into account history when the patient started being conscious about their weight or being conscious about what they eat and exercise, right? I always ask this question to my patients, and a lot of them is childhood, 9 years old. I went on my first diet at 10 years old. So for somebody who has struggled with weight since early childhood or preteen or puberty, then that person most likely will benefit from the medication long term, right? If somebody who just gained weight, many women after pregnancy, right, that they never struggle with weight, and somehow after pregnancy, because of the children, because our lifestyle changes, because we're aging, then we tend to gain 10, 15, 30 pounds, then maybe that patient will benefit short term from the medication, right? And in regards to perimenopause and midlife, so let's talk about this patient that gained weight after pregnancy. They had 2 consecutive pregnancies and gained weight, but now they're in their 40s, right? Now they're in their mid 40s. So now we add other hurdles to the patient to lose weight. So it becomes more complicated. So this patient that didn't struggle with weight, like let's say in your case that you didn't struggle with weight, but you have some family history of obesity or overweight, comes midlife, and the lack of hormones, the drop in muscle mass can predispose you, or everything that I was protecting you or helping you staying in a healthy weight pre-menopause is not there anymore. So it becomes more complicated and more easy to gain weight. And that's what we see a lot of times in women in midlife, that's when the weight starts to show up, right? Because your surroundings are not the ideal anymore to promote you maintaining a healthy weight or making it easier for you to lose weight.
Great. And I think too, the other thing I wanted to make sure that we mentioned, I think that there's a difference. You mentioned at the beginning when we were talking about mechanisms of action with GLP-1, where it will sort of upregulate leptin, so upregulating our satiety and our feelings of being full, and it'll also downregulate or attenuate our ghrelin signaling. I think that that's important too, because one of the things that we see, particularly through the menopausal transition, is these like menopause munchies, right? That everybody talks about, where they're just like they're just starving all the time. They are just, their faces in the pantry, their faces in the fridge, and they're sort of looking for something. So it also does seem that there's this, through the menopausal transition, that there is this dysregulation that happens with some of our metabolic hormones as well, like the leptin feeling full and the ghrelin feeling hungry. And one of the things I like to think about always, and I'm more of an expert in the lifestyle piece. So if you want to, I'm very comfortable just with my training with biomechanics and recovery. And I can talk to you about muscle all day long until the cows come home, and how to, muscle hypertrophy and diet and intervention and stress management. But I think that you have to major in those. Like, I think that you won't be the success that you might perceive on a pharmacological intervention like Ozempic it's not going to be as good as, with the muscle loss and the muscle wasting, as we mentioned, if you're not training. So but I do think that there's this beautiful opportunity for the lifestyle and the pharmacology to really blend and help so many women. I think right now I live in Canada, and I would love maybe your comments on the States, but it does seem right now that there is some gatekeeping around giving some of these weight loss. It's really just for if you are morbidly obese based on the BMI, as you said. And for me, I like fat-free mass. I like the FFMI, which is basically looking at how much metabolically active tissue that you have that is not fat. I like that as a much better measurement than BMI. I think BMI is antiquated, and I have many fitness friends, like lots of muscle, who would be considered obese because of their muscle mass, right? Which is ridiculous. So I would love your opinion on what, if we sort of look at maybe a broader line of, or maybe a sort of a larger delta, a longer delta or longer period of time for these drugs.
Yeah.
Do we see them having maybe more general application, like more mass application for women and men? Who we see men as well who have declining levels. It's not as abrupt, but they do have declining levels of hormones as they age as well. If this is appropriate, as a consequence of aging, as a consequence of change in hormonal status, as a consequence of seeing these body composition changes that happen inevitably for many people.
So before I go into GLP-1s, I do want to say that we know that there's estrogen receptors in the feeding area in our brain. So during menopause or perimenopause, when that starts to fluctuate, we don't have that protective part of estrogen to regulate our appetite. So that's the reason that there's increased hunger in perimenopause and menopause, is because we have estrogen receptors in our feeding center in the brain, which I think it is huge. And we're going to find more and more as hopefully more research in women and hormones is being done. Now, if we talk about GLP-1s, I truly think that GLP-1s is the biggest discovery that we'll have in medicine, probably in our lifetime, that is going to change the way that we practice medicine, that is going to change the way that we live. I truly believe that GLP-1s will add years to our lives, in quality years to our lives, right? Because we're just starting to discover the effects beyond weight of these medications, right? We're finding it's a hormone, right? So we have receptors for this hormone through our body, in our heart, in our kidneys, in our liver, in our brain. And we're seeing more applications beyond the weight loss of this medication. And I can see this clinically. Many times patients start to feel better even before there's significant weight loss happening, because they have a very strong anti-inflammatory effect of these medications, right? So if we go, the problem with this medication, if they have a problem, is the price, is that they're very expensive drugs, right? If we, here in the United States, talking about the United States, if we want insurance to cover the medication, right? If we want the insurance to pay for the medication, then unfortunately we have to adhere to their current guidelines. So if we use Ozempic, Mounjaro, which are FDA for type 2 diabetes, the patient actually has to have an A1C that's showing type 2 diabetes. If we want to use them specifically for weight loss, then they have also their criteria. They need a BMI of 27 or above with one comorbidity, or a BMI equal or greater to 30. So by doing that, we are really minimizing the benefits or that people can benefit from this medication, right? But if we go off label, and if we're doing other measurements, as you mentioned, fat-free mass or percentage body fat or visceral fat, as determinants to who would qualify or who would benefit from this medication, that is definitely more broader, right? If we have a paying out of pocket patient that will pay for the medication, then we can really, what we call off label, then we can really expand who would benefit from this medication.
What is the average cost right now, would you say, in the States? If you're using it off label, it's not being covered by insurance for, glucose control and A1C, et cetera. What would be a monthly estimate of price?
Around $900 to $1,200 per a month supply. But both Novo Nordisk and Eli Lilly, who are the main pharmaceuticals that have GLP-1s right now, they do have manufacturing coupons that cuts the cost 60% or to 50% of the retail cost, right? So there's always coupons or things that we can do to help the patient to pay out of pocket. Now, and I'm saying this that with a caveat, right? It doesn't mean that everybody that can pay for it should be on it, because not everybody who's prescribing this medication should be prescribing this medication, right? To get healthy results, because many times a patient comes with a preconception of an external physical achievable goal, right? To fit and address, to be a certain way, to look a certain size. But when we go, really what weight loss is to improve the metabolic health of a person, right? It doesn't have to be so much with the physical appearance. When we go in a more depth explanation and the understanding for the patient what weight loss means, it becomes complex. Then we have to talk really about strength training, protein in their diet. So at the end, they have higher muscle mass and lower body fat, because that's what we consider a metabolically healthy person, right? We have to explain that to the patient, and you need time. You need, you need to earn the patient's trust. You have to truly educate the patient in regards to lifestyle choices with this medication. That is not as easy. So having said that, I always say the efficacy and the safety of the medication is going to depend on who is guiding you to this process. So yes, most people could benefit from this medication, but not every doctor should be prescribing this medication. So
right. Yeah, I like that. And I think was it last week, just in preparation for our conversation, I was reading a paper that it actually improved insulin sensitivity at the myocyte, like at the level of the muscle, which I thought was, again, contrary to everything that I've heard. It's mainly in social media. Like, you have people that you lose all your muscle mass and you should never, and there's so many other ways. And it's like, I agree that lifestyle, to your point, and I think that you've been very clear here, that you're not going to get ideal results if you're not going to lose fat. We'll say it this way, like, we talk about weight loss, but really what we're talking about is fat loss. Mm-hmm. You're not going to lose the fat if you're not resistance training and doing some of the lifestyle interventions that you've outlined. You will lose weight if you're just doing the pharmacology, but it's not necessarily the weight that you want, that you want to be losing. So when we talk about, expectations here. So if someone is, appropriately managed on this, maybe they're obese, maybe they're, maybe we've expanded the prescription and the availability of the GLP-1s to people who are not just classified as obese. Maybe it's the menopausal women, or it's whomever. What is a reasonable expectation? And I'll be careful with my words here and say fat loss, assuming that you have rapport with the patient is listening to you, they are making better choices with their food, they are getting in the gym and lifting weights, and we are counseling them appropriately, not just to lift heavy weights, but to really approximate muscle failure to drive hypertrophy, muscle hypertrophy. What is a reasonable expectation for fat loss over, let's say, a course of, call it 6 to 8 weeks of this pharmacology with some of the lifestyle interventions?
So what I see in patients with body compositions, really about a pound per week. If you're lifting the weights, if you're eating the amount of protein that you were recommended, you can lose about a pound of fat per week.
Of fat per
So
week. Okay.
maybe a pound to pound and a half per week. That is doable. But anything more than that, there is some muscle loss with it, right? So we go back on who should be, really when we prescribe this medication, we should be doing body compositions because we really need to see, and giving visuals to the patient, it helps tremendously, right? Many patients don't register what's the importance of muscle, right? But we talk about muscle and they think, well, I don't want to get bulky.
Yeah.
But really, when they see how that they lost 10 pounds and they lost 4 pounds of muscle and that their percentage body fat didn't change much,
Yeah.
it makes an impact, right?
Yeah.
And really, patients that we're just concentrating on the scale, they're losing 20, 30 pounds. They don't feel healthy. They feel frail. They feel weak. Versus a patient that's lost 50 pounds of body fat, but they maintain muscle or they gain muscle, they feel strong. They feel the feeling overcomes the looking or how they look, which is, I think if everybody understood that, we would see so different as medications that is about how you feel health-wise and not how you look. I think many people are poo-pooing these medications because they're thinking it an external, superficial
It's a cheat.
result,
It's like you're
right?
cheating. Yeah.
Just to look a certain way. But when the patient understands that it's not about the look, about looking certain way, but about to feeling certain way, it changes something in their mind, right? And there's no going back. Once they feel strong, there's no change.
Is there any, and maybe you've seen this clinically, and I'd love your comment on this, any habituation to the drug? So we know that, for example, when you are a type 2 diabetic and you're taking insulin over time, there's a habituation to it, which will necessitate the increased, you always increase your insulin over time as a type 2 diabetic. Do we see anything like that in a patient who is, let's say, taking these drugs, this class of drugs for 6 months, a year, 2 years, something like that? Do we see a necessity to increase the dose over time?
Well, it's a very individualized plan for every patient, right? The dosing, the time of increasing of the dosing depends on the metabolism of the patient. But definitely the patients that lose muscle, that don't gain muscle, it becomes almost like the drug is doing 100% of the work. Right. So you need more and more and more. For the patients that are weight training, that eating protein, they're more responsive to the medication because the muscle takes also over 50, 40% of the weight loss process, right? So really for those patients that don't gain muscle, that they lose significant amount of muscle, they really depend on high doses of the medication. And we reach a wall, we reach the ceiling with the maximum of the drug, right? But it's not that the medication is not doing the work, it's that the patient has lost significant amount of muscle. And when you're losing muscle, it tells me about your diet, right? It really tells me about your diet. It means that your diet is not high in protein, it's probably high still in food that is very dense, caloric dense. And that's why the medication. So it really, if you're maintaining the muscle, if you're gaining the muscle, I know what you're eating. But if you keep losing muscle, you're not gaining muscle, I also know what you're eating. And you're
Right.
depending 100% on the medication, right? So with patients, what I like to tell them at the beginning, for many patients that have severe obesity, that have to lose 80, 100 pounds, then we want the medication to be doing 90% of the work, right? But eventually, we have to start flipping that percentage, and the patient muscle mass will start to take over. That at the end, the patient's lifestyle, the patient's muscle mass is going to be doing 70% of the maintenance, and maybe the drug will be doing 25% or 30% of the maintenance. So it's really complex. It's not easy.
And two questions that, as you're talking, are coming to my mind. Is there ever a time where you think that a patient should stop the medication or tighter down, like she should titrate down, where maybe, as you mentioned, she's built the muscle, her muscles now, we have this contractile tissue that's metabolically active. Maybe we wean her off of it? Is there ever a time where we can approach the subject of getting her off of it? Or do you believe that maybe someone should be on this, like I remember Mary Claire was like, you will take estrogen out of my cold, dead, hands. Like she wants to be on estrogen forever, right? So which is fine, and it's a decision that she's made. Do you feel like people should be on these peptides, these hormones forever, and then we sort of adjust the dose as needed? Or do you feel like it's a temporary intervention and then eventually we get them off when we've changed their body composition?
It will depend on the weight history of the patient, right? If we're talking about this patient that may be in midlife and struggle with obesity since childhood, most likely they will require a long-term dose of the medication for maintenance. But if you have somebody who never struggled with weight and due to midlife, due to pregnancy, due to some specific event, now they've gained 30 pounds and they cannot lose it, then they may be able to maintain the weight loss just with the lifestyle modification or building muscle, right? And adhering to a high protein diet.
I hear a lot of practitioners now talk about microdosing. I don't know if that's the right term, but I guess it would be just like subclinical levels of taking these GLP-1s to sort of take the edge off. Is that something that you agree with? Don't agree with? What are your thoughts on I don't know if microdosing, is that the right term? I don't know how I would say it otherwise. Yeah.
So first, microdosing can only be done with compounded GLP-1s, right? Because the brand name drug, Ozempic, Wegovy, Mounjaro, they're pre-dose medications that you cannot manipulate, right? So if we're talking about manipulating the doses to microdoses, we're talking about compounded medication to begin with. Second, there's no data, there's no research that microdosing has any therapeutic effect, right? We have our current doses that we know that are therapeutic. Let's say Mounjaro or Zepbound, which is tirzepatide. We know at 15 milligram, we can get 20 to 22% of weight loss, right? So these doses that we have standardized, they've been studied, and we know that at that dose, we reach a therapeutic effect. Microdosing, if you think about it, if we need to get to 15 milligrams of tirzepatide to have that percentage of weight loss, what is a tenth of the lowest dose going to have any effect, any therapeutic effect, right? I think it's more of a placebo effect that we could be seeing, because to reach therapeutic levels, we know the current doses that we have are therapeutic doses. So it's very hard to justify or to say that a microdose will have some sort of effect. Maybe we're not looking for 22% of weight loss, but even at 2.5 milligram, which is the lowest dose of tirzepatide, we may get 5% or 10% of weight loss, right? So if you're doing a microdose to lose 1% of your body weight loss, I mean, you probably don't need the medication to begin with, correct? Also, the idea of microdosing is to minimize the side effects. But again, the side effects are not due to the dose, it's not the medication's fault, the side effects. It's whoever is guiding you and prescribing you these medications. They should know how to manage side effects and prevent side effects on patients.
So let's talk about some of those side effects. I think that, to your point, some of it is clinical mismanagement. I've heard things like stomach paralysis, increased risk for thyroid cancer, although I don't know if that's been done in humans. Yeah, tell us about some of the side effects that we can potentially see, and how we might navigate through them.
So the most common side effects, the garden variety of side effects of this medication, could be nausea. Although the newer generation of the GLP-1s like tirzepatide, we really is minimal, the nausea that we see. compared to Ozempic Wegovy, which is semaglutide. We can see constipation just because, one, the patient is eating less. Second, it does slow digestion. That's how it keeps you fuller for longer periods of time. And also, these medications can cause dehydration, not as a direct effect of the drug, but because we drink our liquids when we're eating.
Oh,
So,
right.
but we're going to be eating less. We're going to be eating maybe twice a day. So then that's the only time that you're going to be having some hydration, right? So that can cause dehydration, and the dehydration can cause constipation. The dehydration can cause dizziness, lightheadedness. The dehydration can cause a kidney stone, right? But those are things that we can anticipate and be proactive and preventable, right? So guiding the patient that you need to hydrate while you're on these medications. You need to be drinking a certain amount of liquids. You should be going to the bathroom every 3 hours to urinate to know that you're hydrated, right? So most of the side effects that really they can be preventable to become a complication.
I want to transition just a little bit because I think that there's a lot of parallels in the GLP-1 class of drugs and testosterone and hormone therapy. I think that previously with hormone replacement therapy, for many, many years, very much poo-pooed. It's going to kill you. You're going to, all this, you're going to have a heart attack. You're going to get breast cancer, all of these things. And testosterone, like GLP-1, I think right now, and feel free to redirect me here if I'm incorrect, but right now, the only sort of approved on-label use for testosterone in women is for hyposexual desire disorder, HSDD. And I think that a lot of clinicians that I've spoken to here on the show, I know that you talk about this as well, are also finding, we'll call them off-label, uses and benefits that women can derive from being on testosterone, TRT, on testosterone replacement therapy. So let's talk a little bit about, I want to talk about testosterone specifically because I've seen you talk about this a lot. What are some of the off-label benefits that a woman might profit from being on TRT?
So unfortunately, right now, the medicine and society, we've minimized testosterone in women purely for sexual function as a sex hormone, right? But it's really a very important hormone beyond sexuality, which is important, of course. But we're seeing many other benefits. So many of the other benefits, it's sharpness, mental sharpness, stamina, muscle recovery, muscle building, right? Decrease in body fat, just overall feeling better. So when we talk about hormone replacement therapy, we're talking more of estrogen and progesterone, right? So many times that's what we're with. But what we're seeing and what we're hearing clinically is that many women are coming and saying testosterone was the missing link. Testosterone was the last piece of the puzzle for me to feel as I used to feel pre-menopause, right? And currently, testosterone, as you mentioned, its only indication is hyperactive sexual desire in postmenopausal women. We're not even talking about perimenopausal women or premenopausal women. Right now, the only guideline that we have is for, and this is very new. This is only since 2019. So 6 years ago, if you would ask me about testosterone, I will be saying it's a no-no for women, right? But and it's very similar to GLP-1s. When we started using GLP-1s 10, 15 years ago, we were using it specifically for diabetes. But we clinicians, we were seeing other benefits when the patient was coming back to their follow-ups. They were losing weight. They were feeling better. And it was independent of the glucose control. And the glucose control was independent of the weight loss. So we started using it off-label for weight loss. And then eventually the pharmaceuticals catch up. They do their research. They do their studies. And the new indication comes in. So I can foresee this happening with testosterone, right? That we are started for one indication, as we did for type 2 diabetes for the GLP-1s, and now we have other indications. Now we have it for cardiovascular disease, for like GLP-1s, right? Not just weight loss and alcohol abuse. We're starting to see that dementia. So I feel like with the testosterone for women, we're going to start seeing the same effects because we started giving it enough for one indication, but patients are coming back and saying, not only is my sex drive improved, but this and this and this has gotten better in my life.
Right. Yeah. And I mean, I try not to put on my tinfoil hat, but sometimes it does have to get on. And I get so agitated with this idea that a woman should only, in her postmenopausal years, is only when the husband, when she, and it's a very subjective diagnosis, right? Like you're not necessarily looking at her testosterone and saying, okay, this is HSDD. You're also going on her and usually her husband's clinical reporting of like she doesn't have any desire to have sex, and and it's in some cases it's to relieve the husband, it's like it's to help the husband with her libido. And I think that it's just, I think for far too long, I can't understand why women have been denied HRT, like, the estrogen and progesterone, for example, which now we're starting to see a resurgence and a turnaround, certainly. But I think testosterone is sort of the final frontier where, a man, all he has to say is, he can go to his doctor and say, I think my libido, I don't feel like exactly the way, and he already has a script for testosterone, whereas a woman really has to fight. And in some cases, I have no libido and it's really dire and my marriage is about to fall apart, in order for people to listen to her. And I just, to your point with testosterone, it has far, far reaching effects other than certainly libido, famous for libido, great. But if we think about combining testosterone and some of the GLPs, right? So now we have the testosterone that's helping to maintain the muscle mass, to help with muscle recovery, as you mentioned, to help with the metabolic correction with, not bringing on too much fat. And then we bring down her consumption of calories through the GLP-1. And we just have this beautiful woman in her 40s, 50s, 60s, 70s, thriving living her best life. Like what is the problem?
You think, what blows my mind away, and I did a post about this, is we will have more years in perimenopause and menopause that we had in our fertile years, right? We concentrate so much on our fertile years, but we're gonna outlive our fertile years. So you're talking maybe 2/3 of your life living in perimenopause and menopause. Why would you settle for less? Why would you settle for suboptimal living just because you're not reproductive anymore, right? Yeah. That's one thing that we have to change. Second, as long as they're not damaging, we should be able to use them for our benefit, right? And I think here's where it gets tricky. Again, not everybody should be prescribing testosterone. Not everybody should be prescribing GLP-1s. I could be prescribing chemo drugs. Would I do it? No. I'm going to create more harm in the patient because I'm not familiar with that.
Just because you can doesn't mean
just because I can doesn't. So that's when we run into problem, and that's why we have guidelines, and that's why we want to stick to the guidelines, and that's why we have evidence-based medicine, is to prevent misuse and creating damage and health problems instead of the benefits. Right. So even for testosterone, you really have to go with somebody. And this is very new for us doctors that are board certified that we're prescribing testosterone. So there's not that many doctors that are going to be familiarized with prescribing testosterone in women and how they should be followed. Estrogen, when we give estrogen replacement, we don't follow levels, right? We go more with symptoms. But with testosterone, we do want to maintain what we consider a normal level of testosterone. We don't want to overdo it because then we can have some negative side effects from testosterone that we can avoid. So you also need to do your homework on who you're going to go for testosterone replacement.
I love that. Yeah, well said. Dr. Rocio, if people want to find more about you and your clinic, I know are you still practicing in New York City? I believe you are. Yeah. Tell people about how they might find out more about you and your work.
I practice and I have my clinic in New York City, and they can find me on my webpage, nyendocrinology.com. And also on Instagram, I talk a lot about GLP-1s, hormone replacement therapy. They're very educational videos, and it's at Dr. Salas-Whalen, DrSalasWhalen.
Awesome. We'll have all of that in our clickable show notes. I do want to just say one thing before we end. I think it was maybe a couple weeks ago, you had posted your workout routine, and the comments, I just have to tell you, were wild. I was reading some of the, it's like, oh, you should, I like that you're doing tricep extensions, but don't you think you should be doing like compound exercises? And I wanted to just tell you, who knows how many people are listening at this point, but the comments were wild, and it's really still very evident to me that we are so comfortable commenting on women and what they do and their choices. It's like, she's working out, she feels good, like leave her the hell alone. Like if you wanted help, if I wanted someone to sort of critique my exercise routine, you would have put in the caption, tell me what I'm doing wrong or what am I missing, or, but you're like, hey guys, I just wanted to share with you, I'm back at working out for a long time. These are some of the reasons why it took me a while to get back to working out, and this is what works for me. And I was just reading the comments. I'm like, I can't believe that we are still in this 2024. We are still commenting on women's bodies and what they're doing and poo-pooing people's choices. So I just wanted to say good on you for all the training that you're doing. I think you had mentioned in your post, like it took you a while because you were sharing joint custody and didn't want to spend any time away from your kids and all that. And as a woman who also has joint custody with her, with their father, and trying to balance all of that, I know how difficult it can be. So just wanted to congratulate you on
Thank you.
being an example of what is possible. So thank you very much for that.
Thank you. Thank you. Thank you.